All right, everybody. So if you don't already know, the Super Mario surgical cap means today was a procedure day. And I had a case today. It's actually a case that I've been working on for quite some time, last few months, that I wanted to talk about today because I think it highlights some important concepts that are sometimes missed in some of the nuances in my posts or in other providers' posts, or that are just missed altogether with some physicians and how they approach treating pain. This patient has a long surgical history for his knee joint. He has had a large number of surgeries, but still to this day, his knee is in pain. Now, some of his knee pain is in part due to some of the surgical scars and things like that, which have created some adhesions in the nerves, in the superficial nerves, some of the deeper nerves, in the fascia, which is changing his body mechanics, how he moves, how he walks. And so he's getting compensatory mechanisms that are kicking in, that are causing some shifting. But he also still has some of the original pain that he went into the surgeon for the first time. And so today we performed our second PRP procedure on him. After the first PRP procedure, he got about a 30% improvement from the procedure, which was about 8 weeks ago, which with the extensive history that he has is absolutely phenomenal. I will also add that he does have a meniscal allograft transplant, and so that makes it a little bit more difficult to treat the knee. And what I mean by that is the actual inside of the knee joint, because that tissue is dead. It's no longer living. It's taken from a cadaver and has been transplanted into him. Now, that is important to frame up because we know that we're not going to get as great of healing with dead tissue, but we also know that not a lot of pain is necessarily going to come from the dead tissue. The pain that can come from inside the knee joint, though, is if that if that meniscus is not doing its job at cushioning the cartilage on the femur or on the underside of the tibia, then we can start to see pain coming from the actual cartilage from the bones. And so he was having some of that, but a lot of his pain was actually coming from the exterior of his knee joint, his pes anserine, the coronary ligaments that hold the meniscus down onto the actual tibial plateau, and the popliteus enthesis, which just means the attachment, but the attachment of his popliteus on the back of his knee. And so in our approach for him, we're taking a very comprehensive, let's evaluate every single structure in the knee that we can and treat accordingly, whether that's the peripheral nerves, whether that's the ligaments, whether that's the fascia, whether it's the muscles or the tendons, the cartilage or the meniscus and the fat pad. We want to make sure that we're evaluating and treating all of that, because in a case like this, where this is a decade worth of knee pain and about a dozen surgeries that haven't fully resolved his pain, it's not just going to be a simple, oh, let's put PRP inside of the knee joint and he's just magically going to be cured. It's regenerative medicine is powerful, but it's not this miracle cure that some people make it out to be. And so we're slowly chipping away at the block for him, where our plan is to do a few PRP procedures to really focus in on what are the most difficult things for him to heal and to eliminate as much noise as we can. So that way we're going to go in with a stem cell procedure in the future, and we're going to be very hyper targeted on that stem cell procedure. So for example, we may resolve all of his main issues except for the cartilage defects that he has inside the knee joint, and maybe, and again, this is just spitballing hypothetical, but maybe the popliteus attachment onto the femur. So now when we go in with the stem cell procedure, we can put a high dose of live autologous, meaning they came from him, from his bone marrow. We can put a lot of stem cells into the knee joint, as well into the popliteus insertion in order to maximize the healing there. In a case like his where it's extremely complicated, it's probably one of the more complicated cases I've worked on, we have to be careful not to just immediately jump to a stem cell procedure, because we could be doing too much in certain areas, not enough in other areas, and we might not get a good or as good as we can clinical outcome. And so that's why, to me, my approach with this patient is to do several rounds of PRP first before going to that stem cell procedure, so that we can be really accurate in where we are injecting and what we need to be treating. This also brings up another point, which is that almost all of his surgeries have been focused on his meniscus. Oh, you have knee pain, you have meniscus tears, meniscus. And that, I think, has resulted in the other physicians forgetting about the other structures around the knee that can also be contributing to pain. A lot of those other structures don't have any changes on MRI, and so some physicians look at that and go, well, there's no issues with anything else. Meanwhile, there's a lot of issues in this patient that are coming from areas that are not showing up on an MRI. And so that's why it's extremely important that you're working with the physician who takes the time and effort to do a full, thorough physical exam, correlate that with your history, correlate that with any imaging studies that may be needed, and not just treating and relying on the imaging. I hope this brought some insight and value into how I approach working with my patients who are in chronic pain and are looking for alternatives like prolotherapy, PRP, and stem cell therapy. If you like this video, please hit like, subscribe, whatever it is. Leave me a comment on what you liked most about it, what you want to hear more of, so that way I can make sure I'm giving you guys what you want to hear. See you later.